We have 10 people. Can we start, sir?
I'm surprised, because Chattal is always
We can't hear you, sir.
always kept an exam, and I'm surprised so few of our students are interested in that, isn't it? How many people have logged in? 7, 6. Anyway, proceed. Can you hear?
Yes, sir.
Okay.
Okay, let us start.
Okay, sir. Can you hear me, sir? Good morning, sir.
Start, please. Yeah.
Good morning, but your slide is not coming up. Oh, okay, now it's all right. Okay, start.
Good morning, everyone. Presenting a case of a 1-year-old baby girl hailing from Bangladesh. Informant is mother, fairly reliable. Presented with chief complaints of loose stools 2 months back and fever 2 weeks back. History of presenting illness. She was apparently all right 2 months back, and then she had loose stools, 5 to 6 episodes lasting about 5 days, not requiring any hospital admission, and then was referred on consultation at a clinic, was referred to a higher center, and then she was later on diagnosed with a heart defect, and then she was referred here. She also complained of fever, which is low grade, 2 weeks back. Uh, Mother gives no history of respiratory tract infections, no history of labored breathing, no history of feed intolerance or any refusal to feeds. There is no history of any exertional intolerance, no history of bluish discoloration of skin or mucosa. And there is no history of poor weight gain. There is no history of limping or any syncope.
What is-
Birth
What is limping to?
What she means probably is limp, this thing, not responsive. Is that what you're saying?
Yes, sir.
Limping happens when you are walking.
Okay,
When
yes,
your
sir.
child does not walk.
It is I think 1 year, 3 months old, sir. Baby walks now.
Excuse me. Okay.
Birth
See,
history.
when you present a history, you have to be very clear what you are trying to convey to your examiner.
Okay, sir.
Okay. So don't do direct translation from your regional language to English. So use standard terminology, whatever has been used to, and then only talk about it. Don't introduce your own terminology and your own words. Okay, very important, because it conveys a wrong meaning. When you say a 1-year-old child limping, that means there is some neurological problem.
Okay, sir.
Yeah.
Moving on. Birth history. It's a second order full term with the CS section. With the previous section, baby cried immediately after birth. Baby is birth weight 2.6 kg. There is no history of any NICU admission. Baby had exclusive breastfeeding till 5 months of age. Family history. It's a non-consanguineous marriage, and the firstborn is male child, 4 years old, and a healthy male child. Immunization history is up to date for the age. Milestones, both motor and social, attained for the age. General physical examination, baby was.
Hold on. You're still at history. You have to pause there. What do you make of this history? Can you suspect heart disease in this patient, in this child?
Was actually baby was referred from the pediatrician to the higher center. So basically an asymptomatic.
From the history, you cannot make out that this child had heart disease. Only because she was referred by a pediatrician. Fine.
Yes, sir.
So 1-year-old child, you have to think about, there is no cyanosis, there is no respiratory infection. So it could be anything,
Yes,
isn't
sir.
it? It
Yes,
could
sir.
be a acyanotic heart disease with left to right shunt. It could be a cyanotic heart disease with a mild cyanosis not missed. So anything can be there. So, okay, go ahead.
Yes. Coming to general physical examination, child was examined in mother's lap, comfortable. The weight was 7.2 kgs. Examination, vitals, blood pressure, 88 by 54 millimeters of mercury. Heart rate 120 beats per minute, regular, no radioradial or radiofemoral delay. 24 cycles was the respiratory rate. Baby was febrile. Room air saturation when examined was 85%. Coming to head-to-toe examination, baby with fair skin complexion. There were on the right side preauricular skin tags noted. Pinna was otherwise normal. On the cheek, there's an induration with inflammation size about 2 to 2 centimeters with punctum and pus discharge is there. No pallor, clubbing, icterus, cyanosis, edema, lymphadenopathy noted in both. Nothing was noted in both upper and lower limbs. JVP was not raised. Coming to cardiovascular examination.
Hold on. For the benefit of others, you could have at least taken a picture of this periauricular skin tag so that not everybody will see this. And does it conform to any known syndromes, which is seen in infants and neonates? Okay. See, when you see something abnormal, it is nice to share it with others. Not everybody can go and examine this child, right? So periauricular skin tags, right side. So it is an important finding because there is no other symptom seen. It's a sign seen. Okay, in general exam. Okay.
Moving on to cardiovascular examination. On inspection, the chest, there were no scars, no visible pulsation, chest was symmetrical. On palpation, apical beat was felt along mid-clavicular line and fifth intercostal space. There was a systolic thrill over the left parasternal area, mainly in the second left intercostal space. Auscultation, the normal S1 heard, S2 was loud, and there's a systolic murmur with intensity 4/6 gradient over left parasternal region, and it was radiating to upper parasternal area. There were no other murmurs appreciated.
This does not go. You have a murmur in the left parasternal area, 4 to 6, and then you're saying loud S2. They
Yes.
don't correlate well.
Parasternal region, and it was radiating to upper parasternal in the second intercostal space. So
Okay, you think what do you think that murmur is?
from the clinical findings, it can be a VSD with a small VSD with restrictive left or right shunt.
VST. VST does not give you a systolic ejection systolic murmur grade 4. Okay, all right, fine, all right, okay.
No other murmurs appreciated. Respiratory system, normal vesicular breath sounds heard. Coming to central nervous system, no sensory or motor deficits noted. Per abdomen was soft, normal bowel sounds heard, no organomegaly. The clinical history, nothing could be made out from the history what mother gave, and from clinical examination, apart from saturation on room air, it was 85, and no sinus was seen in the fair complexed baby. Even on the mucosa, it was all bluish, all pink, and no clubbing noted, sir. And on examination, clinical examination, the positive findings are only a systolic thrill and a systolic murmur of grade 4/5 in the left parasternal region. Uh, from this, given history and the clinical examination, provisional diagnosis could be congenital heart disease with shunting post tricuspid level, probably a left to right shunt with no features of congestive heart failure or thromboembolism or infective endocarditis. I would like to further confirm the diagnosis with the ECG, chest X-ray, and echocardiography.
Okay. All right.
When you describe a systolic murmur, you have to say it's a pan-systolic murmur, not an ejection systolic murmur. Most important, that's why you have to differentiate between a VSD. VSD always gives a pan-systolic murmur, whereas pulmonary stenosis or part of infundibulous stenosis, they give ejection systolic murmur. So, and then your finding is that it's a small VSD or large
Yes.
VSD. Or better, you got
With
already
systolic thrill, with systolic thrill and grade 4/6, it's a restrictive small VSDs from the clinical findings.
But then P2 is accentuated. In a small VSD, do you expect the P2 to be accentuated?
If there is severe PVR is high, then only the closure will be loud. That time P2 can be loud. Otherwise, in a small restrictive VSD, it is unlikely to get a loud list.
A totally asymptomatic child. Totally asymptomatic child with a loud P2. No history, antecedent history, not on any treatment for heart disease is unusual.
Only last week we discussed a small VSD is defined. I gave you all this. And in which the shunt is less than 1.5:1, and the pressure in the right ventricle and the pulmonary arteries are much less than the systemic pressure of the left ventricle, So that's a normal pressure in a small VSD. And in a moderate VSD, we said the pressure may be normal to 2/3 of the systemic. Very large VSD, there's equalizer to the pressure between the left ventricle and the So if you definitely say small VSD, that doesn't give rise to pulmonary hypertension or pulmonary vascular disease. There is something wrong better than the elicitation of the clinical findings. Anyway, let us see. The whole thing doesn't very well. Like the
Sir?
presenting symptom, diarrhea, so it's all very confusing to the examiner. The mother may say so many things, but you have to analyze it and present. First, say what's the most important presenting symptom. Okay. You can mention the diarrhea, but that should not be the presenting symptom.
Okay, sir. So, standard 1 lead ECG with a heart rate of 150, normal PR interval with sudden transition in the seen in V2, and right ventricular hypertrophy noted with Q waves in 1, 2, and AVF, which is counterclockwise, and there is a right axis deviation with the 130-degree axis. Um,
The slide is not moved, still on diagnosis. Put the
No.
ECG on. Okay.
is it seen, sir?
Yeah.
Yeah.
Standard 12-lead ECG, the heart rate of 150, sinus, normal PR interval with sudden transition seen noted in V2 lead, and Q waves is noted in 1, 2, and AVF. Right ventricular hypertrophy is there, and right axis deviation noted with axis of 130. Shall I move on to chest X-ray, sir?
So what do you make out of that ECG? You didn't tell us.
With the findings of right ventricular hypertrophy, it's more likely in favor of cyanotic disease with tetralogy features. Like with the clinical findings, it was a VSD, but VSD with right ventricular hypertrophy is mostly a tetralogy feature.
In the exam, please don't say that it is tetralogy. Okay? Because the examiner will know that you know the diagnosis. So on the ECG, you cannot comment except for the unusual feature of it's not really sudden transition. V1, V2, V3, it's gradual progression of the R wave.
Okay.
Okay. So it's not a sudden transition from a negative wave to the positive wave.
It should be early and sudden trans between V1 and V2.
So this is gradual progression of the R wave. So you say it is not, we are not able to say anything conclusively on this ECG. You are safer that way. Okay.
Okay, sir.
No.
Yes, sir.
Don't bring in the diagnosis at this stage because I agree that you have seen the echo, you have seen everything else later on, but in the exam, be careful when you say the diagnosis at what level. We can't make out a diagnosis on this ECG.
Yes, sir. Chest X-ray, PAU, well centralized and well exposed. Levocardia, levocardia with situs levocardia with CT ratio of 0.5. It's RV type of apex. The PA segment is empty, and other cardiac borders, are normal with lung fields appearing normal.
The PA segment is not empty. And this is not the boat-shaped heart.
There
It's
is mediastinal. No, there is mediastinal widening, probably a thymic shadow in a
Yeah.
child. In a child, okay.
1 year.
And
Yes.
there is one very grossly seen finding. What is the tracheobronchial tree? There is gross deviation of the
The
bronchus.
right side.
There's indentation there. Okay.
Coming to echocardiography, 2D echo, it's a levocardia with a large malaligned conoventricular VSD with severe PS, with a small ASD, confluent branch PS, and with a left aortic arch, with a good biventricular function. The coronaries have been mentioned as unclear. Apart from that, there is the systemic venous drainage and the pulmonary venous drainage are normal. Uh, Features are suggestive of petrology of fellow.
How do you, what is the things that are known to give you a concrete diagnosis of tetralogy on the echo?
In a four-chamber view, you can make out the overriding of the aorta, and
In other words, what is the differential diagnosis of tetralogy and how do you differentiate them?
more than 50% overriding of the aorta. It is like tetralogy fellow is most likely. Others like DORV, the aortomitral continuity is lost. So in a four-chamber view,
That is important. Aortomitral continuity is lost in DORV. It is maintained in tetralogy. Okay.
is
Then there is a malaligned VSD, and the overriding of aorta is sometimes, different people have different definitions. But the aortomitral continuity is important to know
yes, sir.
on the echo. All right.
Yes. So since they have mentioned coronaries are unclear, would like to further go ahead with the CT for the coronaries anatomy, if any crossing over the RVOT to confirm.
Have they done it?
Yes, sir. CT cardiac angiogram is done. The features are conforming with that of the 2D echo, and the coronaries, no major coronaries passing except for a small coronal branch, and there is a aberrant right subclavian artery, and the Megone's ratio is 2.4.
Okay. So coming back to the diagnosis of this child, what do you think she has? She has a features of tetralogy. She has got an aberrant right subclavian. She's got an ASD. All right.
Pentology, yes.
And so all these things have to be tackled at your surgery.
Yes.
So these are the things that you have to know.
Yes.
What is a pink tetralogy?
A cyanotic trough with features that are similar to a small to moderate VSD with left to right shunt. And clinically, the cyanosis is not evident.
But you said there is severe subvalvular, infundibular stenosis on the
Yes.
echo. It doesn't correlate, right?
but baby is not symptomatic so for the given finding. So should we comment it as a pink top or not, sir? On saturation monitoring that I saw the trend, it was 83, 85, and in only twice readings it was 79, 80. Apart from that, it was 85, 86, 83 in this range.
Okay, so there is desaturation.
Yes. But for a cyanosis in an Asian population, it should be at least less than 85% to make for the evidence or for the, to catch it, like for the eyesight, even in a fair complex, it is not there.
Hmm.
Very
Okay.
pink.
All right.
Classical tetralogy of Fallot. On auscultation, what is the second heart sound like? Here, you said exactly the opposite. What is the classical second heart sound in a tetralogy of Fallot?
It's a single soft S2 heard. S2 is heard in a classical DOS.
Here you said P2 is accentuated, which never occurs in a severe pulmonary valve or infundibulous stenosis. And the pulmonary second sound is soft or absent. And because the aortic sound is more prominent, and mainly because aorta is large, it is rotated and it's more anterior. So what happens is that the aortic second sound is prominent. It may be single because you may not even hear the pulmonary second sound. Here you said A2 normal, P2 accentuated, which actually you can never explain that. Anyway. So generally, what time the cyanosis appears in tetralogy of Fallot? This is a usual question examiners ask you.
More than 6 months of age.
Not correct.
As early as it can present is 2 to 3 weeks, but presentation is fine.
It's very often slightly delayed because the reasons we have explained 10 times. But why is that delayed? Because in a transposition, the baby is cyanous from the day of birth, or in a like I said, the 3 pulmonary stenosis, they're all cyanous from the birth. But in tetralogy, usually it is not. Why is that?
One is the infundibular stenosis becomes progressive and then later on fixed.
No. Sorry. That is a cyanotic tetralogy becoming cyanotic later
Yes.
on. But why they don't present in the first 2 weeks or so?
Because of hemoglobin F increased concentration in the infants and the compensation with polycythemia and increased affinity of oxygen to the H F hemoglobin than the adult. Once the baby turns more than 6 months, the transition from F to adult type.
Yeah. Why don't we answer? One reason is that PDA may be patent for some more time in those cases. Okay? When the PDA closes, they become more cyanotic. This
Yes,
we
sir.
describe the physiological closure anatomic, but it's usually 2 weeks. And the other use is the presence of a fetal hemoglobin. That,
Yes.
why is that? What is the difference between adult hemoglobin, okay, and fetal hemoglobin?
more affinity for the oxygen in fetal hemoglobin than the adult?
Simply say the fetal hemoglobin shift the oxyhemoglobin dissociation curve to the left.
Left
So
to right.
it has got the capacity to carry more oxygen and in the tissue supply. It's because in utero, the baby gets the oxygen from the mother's blood. And so in such cases, to carry more oxygen, the child has got the fetal hemoglobin. Around the 4th week, about 40 weeks, just about delivery, the amount of fetal hemoglobin comes less. And then after birth, even after birth, about 50 to 60% is fetal hemoglobin. And it may last even up to 6 months. This is a classical textbook description. So because it shifts the oxygen dissociation curve to the left side, the cyanosis may not be there in cases of presence of fetal hemoglobin. And in many cases, the presence of PDA is some blood supply even in severe tetralogy to the lungs, and there may not be cyanotic. So classically, they say 70% of the tetralogies are not cyanotic at birth. Then 50% are cyanotic by 6 months. It is a classical teaching, you should know. Okay.
Yes.
So presence of ductus and the amount of fetal hemoglobin. The other thing, delayed thing is actually the progressive infundibular stenosis that occurs that may turn a cyanotic tetralogy to
Cyanotic.
cyanotic. So the second heart sound is very important in the diagnosis. And ejection murmur. Just a ventricular septal defect doesn't give ejection murmur. It gives a pansystolic or a hollow systolic murmur.
Do you normally see a thrill in a tetralogy? Feel a thrill?
If it is a severe RVOT with attrition, then there is no. It's a soft S2, and it's almost like a silent chest, silent
It is
precordium.
Yes, quiet precordium and a silent chest is the norm. And generally in a tetralogy, the classical description is an unrestricted malaligned VSD.
Large malal.
There is
Yes.
no murmur across the VSD in tetralogy. The murmur that you hear is across the RVOT. And RVOT murmur that generally does not produce a thrill. So I don't know whether your physical findings was right, or if not, how do you explain this? Could this be D or V?
Yes, sir, but not correlating with the ECG and echo findings.
You must say DRVPS. Okay.
Yes, your VPS, yes.
Other thing is, what are the levels and what are the levels of obstruction? Because the most important deciding thing in tetralogy is the RV outflow. Where is the
Yes.
obstruction? What percentage? And that is your general idea of the RV outflow obstruction generally in tetralogy.
Three level obstructions are valvular, subvalvular, and supravalvular.
I will not say valvular first. And the most
Subvalvular,
important thing is the
infundibular.
percent any textbooks will give you 45% of them have infundibular stenosis, and another 30% have got infundibular plus valvular stenosis. That's about 75. Isolated valvular alone is very rare, only 10%. That's not actually a tetralogy. That's a pulmonary stenosis with VSD.
SDPS, yes.
And Annular stenosis also may be present in about 10 to 15%. Then hypoplasia of the pulmonary arteries. Then pulmonary artery branch stenosis. Mainly the left may be present in many cases. And peripheral pulmonary artery stenosis in some cases. So this should be your answer of what is the level of the severity of cyanosis also always depends on the RV outflow. Very rarely, pulmonary atresia may be cyanotic number. Otherwise, pathologies are not usually, maybe very severe pathologies, really are cyanotic. But otherwise, they got a delayed onset of cyanosis. All right. So these are some of the basic things for examiners to ask you. Cyanotic spells is more common in a very severely cyanotic baby or in a less cyanotic baby. The cyanotic spells are not seen in very cyanotic. Usually,
Deepening of the sinus.
Yeah, because
Yeah.
if you follow the theory of Paul Wood, the infundibular stenosis, that occurs at times. So infundibular stenosis, sometimes it opens, so it allows blood to the pulmonary circulation, and they're not very sinus. Whereas when the infundibular spasm occurs, they become more cyanotic. So it's more common in the most, not in the most cyanotic, but at what age do you get cyanotic? Most commonly.
More than 2 to 3 years.
My God, no.
6 months cyanosis you get, so but cyanotic spells as such, they'll get used to.
Hello, madam.
The-
We have
exactly
discussed
the
this so
opposite.
many times.
2 to
The
6 months
classic
is the classic
description of a
development.
spell
Yeah.
is between 6 months to 2 years. Beyond 2 years, it will not happen.
So the classically, it's not years, 2 to 6 months actually. After that, when the child starts walking, they get squatting. So that's 2 years will be probably the time of squatting. And then they will ask you the explanation for how squatting, all those things. But the maximum cyanotic spell occurs between the second and 6 months of the baby, not 2 years. Okay, all right. And then you should know everything about cyanotic spells, the reason that we have described many times, how to treat, manage the emergency unit.
Don't you all make notes when you are attending these classes? Or you just come and go, all of you all? For the last 5 years or 8 years, we have been talking these things every time a tetralogy is presented. What are the causes of spells? How do you treat the spell? What is the mechanism to counter that? What are the what happens in squatting? What are the squatting equivalents? All these things we have discussed so many times. Every time a new batch comes, they think that it's like almost we are starting afresh. You all have been attending for the last 5 years. Chalo.
So what are you going to do? In
1.5 years old.
In
Does
this
this
case,
patient require surgery? If she requires surgery, what surgery? And when will you do it? These are the three questions you have to answer.
Yes, 1.5 year old. So it's from the echo findings and the CT, it is surgery is favorable. The anatomy is favorable for a surgical total correction, and go ahead with surgery. Uh, Intracardiac repair with release of the RVOT obstruction and VSD closure.
is it baby on beta blockers or anything?
No, sir. Baby was not on any medicine.
Okay. So the examiner then asked you, what's the timing of surgery for tetralogy?
More than 1 year of age is ideal, but however, institutional criteria and the weight of the baby, now more than 6 months of age, uh, uh, total correction is being considered.
Yeah, it depends on the institution also. There are a lot of surgery in good pediatric cardiac surgery centers where they do correction rather than a shunting. Right. Aorta pulmonary shunt even at the age of 3 months, but generally accepted. A patient is cyanotic and doesn't need any of the beta blockers. Usually, in our hospital, 6 to 12 months. The child is not very cyanotic, but still that all is diagnosed. The surgery is done between 1 and 2 years. Probably in our hospital, it's 1 year. The other thing is, those people, then if the pulmonary annulus is small for the age, then they will definitely require a transannular patch. In this case, less than 3 months, they don't do total correction. And this annulus is measured by the Z value of the pulmonary annulus. What exactly you mean by the Z value of pulmonary annulus? This is
Given
what is the idea of measuring the Z value of the pulmonary annulus?
uh, given the variation across the above the standard deviation, if it is less than -7, then it is not favorable for.
-7. You cannot. That's almost a pulmonary atresia.
Yes, in that case, it is not favorable for correction.
No, there is no -7. Never described in any literature. Most people used to describe -2. Nowadays, people say -3. If the Z value is more than -3, then they don't need transannular patch. That's because Kirkland said in a baby of less than 3 months, a transannular patch is not tolerated well. So that's accepted thing. The Z value is more than -3. You can do a correction because preoperatively you can predict whether this patient is going to require a transannular patch. Then the other two things are Magoon ratio and the Nakata index. That also you should definitely know what in Magoon ratio when you operate, in Nakata index when you what's a normal and when you do operate.
Nakada 200 to 250 normal, sir. About 100 without pulmonary atresia, correction is feasible. In Magoon's More than
Nakata-
0.7.
Nakata is not 200.
Normal
Yeah.
is
No,
2.
no, it is 300. Some people say even 330. 300 plus or minus 30 actually. No. The normal Magoon ratio is between the ratio
2 or 2. Yes.
2 to 2.5. And
Yes.
our time we all used to say that if the Magoon ratio is less than 1.2, don't do a total correction. But now the surgeons are experts, so the classical teaching is if the Magoon ratio is 1 or above, you can a total correction. For a Rasterly, it is 1.5, and for a Fontan, it's about 1.8. These are given in all textbooks actually. And the
Yes.
Nikata index also, some people say, is 100 millimeters square per meter square. Then less than that, total correction is not possible. About 115 for a Rasterly and about 200 or something for a Fontan type of correction. So don't say Nakata index 250, it's 300 or more. So all these things simple, write down, so that you remember. Then, of course, in this case, normally a good 2D echogram will give you a correct idea of the proximal coronary arteries. We are interested in proximal coronary arteries, whether you're going to damage it doing transvalular patch. If you don't get it, you have to go do CT angio. It's
Yes.
been done, sir.
Yes, sir.
What's the percentage of abnormalities of coronary arteries in pathology of to know? It's 5%, they say. And the most common is what?
Origin of the coronal arteries
Most
and
common anomalous coronary arteries in pathology of
கொடுக்குறேன்.
Huh?
coronal artery or the LAD arising from RCA.
Don't say coronary artery of the LAD. The coronary artery rising from the RCA becomes the LAD. It can replace the whole LAD, or it can replace most of the LAD, and then maybe a small LAD arises from the left main coronary, but main part of the LAD is from a cornus branches, which crosses near the area where you're going to enlarge the outflow. That's a contraindication. So if you can't find that out in a good 2D echo, then you advise a CT angiogram. Then if you find that coronary, how to deal with it. If there's a large coronary artery crossing in a 1-year-old, no, 6-month-old baby, what's your line of treatment?
If it does not require transannular patch, then the transatrial and repair can be enough. If it requires, then we have to wait for more than a year for the baby, because the smallest available conduit we put
You
is
can't wait
uh,
1 year in a patient like that. That's all you require
we keep
surgery.
systemic palliation can be done until then.
That is the classical thing actually. Because you don't want to put a Rasterly type of surgery in a child less than 1 year old, So if this cyanotic baby comes a shunt. A shunt is a modified BT shunt. What is the approach modified BT shunt in Narayana?
Thoracotomy approach.
No.
I thought everybody has
No.
switched to median sternotomy.
Now, thoracotomy is
Except Colin John, all the others have shifted to median sternotomy. What is the disadvantage of doing a VT shunt from the left thoracotomy? Previously, we always used to do the left thoracotomy and do not a classical, but a modified VT shunt. What the measurement of the cortex graft you use?
depending on the age and the weight, sir. 4, 5, 6, and 8 mm are used.
8 mm.
Last is the 8, sir. But mainly 4 to 5. 4.
The smallest you can use 3.5 millimeter. So anything above 3.5, so 4 millimeters classically used. Yeah. The disadvantage of doing it from the one, as the child grows, because you wait about 6 months to 12 months, the more distortion and pulling of the pulmonary artery and distortion can occur if you do from the left side, VT shunt, then chylothorax, then injury to the recurrent laryngeal nerve. So most people, those days we never used to do a median sternotomy because for a correction you need a second operation to the same incision. But now all surgeons are expert in redo. So nowadays, generally in Narayana Vidyalaya, most of the shunts are done through a median sternotomy. In which case, there's no scar on the chest also, and the distortion of the pulmonary arteries. It's done to the right pulmonary artery between the aorta and the
Between subclavian
superior vena cava. You attract the to the side and previously some people do the central shunt from the main pulmonary artery to the aorta with a graft. That's not done now with this, I think, What you've done is a modified BT shunt. And what is the Roger Me operation, for pulmonary atresia?
transecting the NPA and the distal is directly anastomosed to the ascending aorta.
Very good. Because it's a pulmonary atresia, there's no flow through that.
Pulmonary, main,
You can
yes, sir.
dissect and cut out the pulmonary artery just above the valve, and because valve is atretic, then you can make an end of this pulmonary artery to the side of the ascending aorta. That's a Me shunt. And of course, the water stand and pot shunt, which are described only in literature now. Nobody does those things. So the thing is, a BT shunt approach from the left thoracotomy or to the median shunt. Classically done in our hospital.
Yes. These days, thoracotomy approaches.
What is the alternative with cardiologists do a lot of procedures now.
Yes, RVOT stenting, balloon pulmonary valvotomy to release the RVOT obstruction, and PDA stenting as well.
PDA stenting. Earlier they used to say the catheter pulmonary valvotomy and dilatation of the infundibulum. That never works because infundibulum you dilate, so you have to put a stent in the RV outflow. Okay? And these are the two things that now done nowadays. Previously, they used to do some Brock operation. Devi Shetty always says a Brock operation. This is a long time ago, maybe in the 50s and 60s. Not done nowadays. They used to but not on put on bypass, but closed infundibular resection with a tonsillectomy and closed pulmonary valvotomy, so that the infundibular obstruction is released and that a forward flow. The importance of forward flow through the pulmonary valve allows expansion of both pulmonary arteries equally, whereas you do a modified BT-shunt on the left side, there's a differential development of the pulmonary artery. And then kinking may occur, stenosis may occur. So nowadays probably RV stenting is a good thing because the forward flow from the RV expands both pulmonary arteries. What is done in this hospital? Ductal stent or RV outflow stent?
Both, mainly ductal stenting and even RV. Initially, they used to do RVOT stenting, but now mainly PDA stenting is done.
The only thing, PDA stenting is more difficult to remove than RV stent. Okay. Then what are you going to do in this case?
A total correction.
How do you decide to do a transannular patch, and what is done in our institution? In this
The pulmonary
patient,
annulus is
yeah, go ahead.
the transannular measurement for the given age using the Rolet's table that is compared in the echo findings, and intraoperatively once the transatrially after releasing the RVOT and coring out the RV obstruction, Hagar dilators are passed, and if it is adequate, then the transannular patch is not required. If the adequate size dilator is not being passed, then transannular patch is required.
Yeah.
So the
Ideally, the Magoon's ratio and Nakata index is to decide whether you can do an ICR or you should do a palliative shunt. And the
Yes.
Z value is taken as an indication for transannular patch, but nobody does the Z value. Nobody calculates the Z value preoperatively most of the time. So on table, you pass a Hagar and then compare it with a nomogram that is available and to see whether the annulus is adequate for that age. If not,
Yes.
then you'll decide on a transannular patch. That is what is practically followed in most theaters, including our.
Yes.
The only thing is that transatrially alone, that is my impression, you cannot assess the pulmonary valve stenosis and do a proper pulmonary valvotomy. So we used to do transatrial plus a small vertical pulmonary artery. Then the pulmonary valve stenosis and the pathology most of my bicuspid. Not only they're narrow, but the annulus of that is always attached to the pulmonary arterial wall. So to do a good pulmonary valvotomy, it's always better to do a small vertical pulmonary artery incision. You do the pulmonary valvotomy. You're already approaching transatrially. Then you pass a Hagar. Then you will know. And From the nomogram, you can calculate, and you should realize that these patients are cardioplegic, so they're more distensible. So you give 11, at least one size bigger than that. So ideally, I would answer it as a transfacial resection of the infundibulum. And nowadays, they said babies, they get limited excision of the infundibulum, not the coring out of everything, including the moderator band, but to a small vertical pulmonary arteriotomy and do good pulmonary valvotomy, a good pulmonary valvotomy. Unless you are a great expert, you cannot do it from the atrium. And that's my feeling. And pulmonary arteriotomy is not a big thing, I
Yes.
think that's my idea. All right. Isn't it better, Krishna, to
Yes, sir.
do
Yes.
a good pulmonary pulmonary valvotomy from above, from below to do that is, I tell you, very difficult.
Correct. And another practical tip is the difference between an aortic valvotomy and a pulmonary valvotomy.
Yeah,
In a pulmonary valvotomy, at the commissures, you make a small transverse incision as well, whereas you don't do that in the aortic side.
Yeah, aortic is stopped about 2 millimeters beyond the attachment to the annulus, Otherwise, it produces severe aortic regurgitation. And a little bit of pulmonary regurgitation is tolerated.
I think it's already 8:30. I don't think we can discuss more.
Yeah. Actually, a lot more to discuss, about the complications. But anyway, you can't do all those things today. And most importantly, nowadays, everybody says these patients have to be followed up by MRI from the 10th year
For
onwards.
yes.
Yeah. Because of the late development of pulmonary, the right ventricular dilation and dysfunction, and the necessity for pulmonary valve replacement. You study those things, we'll discuss some other time. Okay, thank you.
Yes.
Yeah. Thank you, sir.
Thank you. Thank you, sir.